Hi, I'm Karen, and I would just like to introduce you to Mary Elizabeth Kovacic Eicher. She's a medical doctor, and she's with the Excela Medical Group, and her office is in the Greensburg Medical Commons building. Her primary specialty is neurology. Neuropathy on the brain, yeah. And it looks like she had most of her education at the Hershey Medical Center of Penn State, clear through from her MD to her fellowship. And on a personal note, she's been our doctor, my husband's and mine, for several years. Very attentive to our needs and follow through up needs too. Her and her staff have been great. They've gone above and beyond on all our recent things. So we greatly appreciate her and thank her for coming. And we'd like to welcome you and thank you for speaking tonight with us.
Absolutely.
Thank you. Anything to that?
No, I'm actually local. So I grew up in the area. So our meeting tonight is in the Greensburg, Pennsylvania area, or Irwin, which is outside Greensburg. And I grew up in a small town outside Pittsburgh called Blairsville. So grew up with about a town of 3,500 people. And I've grew up in this town of, in Southwest Pennsylvania. And so my goal when I was studying was always to sort of go out, learn specialty care, and then bring it back to the area. So my plan was to always come home. And so I did my undergraduate at the University of Notre Dame. I did some graduate education. I did my master's in public health at the University of Pittsburgh, and then went to Penn State Medical Center, Penn State Hershey, for my medical degree, my residency in neurology, and then my fellowship in neuromuscular disease. So that's where I get my work in neuropathy, my work in ALS, my work in myopathies or muscle diseases. So we do an extra year of training. We can choose things like stroke and multiple sclerosis, and my passion has always been nerve and muscle, or what we call the peripheral nervous system. So when you think about nerves and muscles, and when you see doctors for that, they'll be neurologists. But then some people like to focus on the brain or the central nervous system, like stroke, Parkinson's, multiple sclerosis. And then other people focus on the nerves and the muscles, and that's the peripheral nervous system. So that's me. Here in Greensburg, I am actually the director of neurology for Excela, our hospital system. So I head up that team. We have currently 6 neurologists, 2 that practice inpatient and 4 that practice outpatient. And I see anything, but often if people need a nerve or muscle consult, then some of my colleagues will send them to me. If we need even more help, we're very lucky because we have access to academic centers very close by. So people that have clinical, systems that have clinical trials available for some of our patients with certain nerve and muscle diseases, we can send them right into Pittsburgh. So I've been here now 2.5 years. Time goes fast. And I love it. And I wouldn't change anything. I plan to stay until Excela tells me I can't. But I always tease them about that. I really like the system. And I really, when I was looking for a place to end up, I started just calling hospitals back here because I had told my parents and I told everybody I grew up with I was coming, I wanted to come back home. It was never about going to a big city or staying in Hershey, although it was lovely. It was about really bringing care here. Growing up in a town like Blairsville, you meet patients or you have friends and family that, we went into the city, but we didn't want to have to go into the city if we didn't have to. And it's that small town lifestyle that really drew me back here and what I love. And I love walking down the street and seeing people I know. I like going to church and seeing my patients. I like walking into the grocery store and seeing my patients because I think it's important that patients see that we have a dedication to the same town they're a part of and the same community they're a part of. And I'm really invested in the health of this community. And so part of my goal when I called around to different hospital systems was really finding one that shared those same values. And I have to say that Excela does. It's been a blessing, and they've allowed me to practice medicine the way I want to practice medicine, which is to really focus on the patient. And they let me spend the amount of time I need to spend with people. And my patients all know I always run behind because you'll see tonight I talk a lot. And it's hard to make me quiet. But I like that because I like getting to know things about people. I like getting to know something personal about people. And that's why, I first went into medicine. I thought I'd do emergency medicine. And then I realized the next day I'd be trying to figure out what happened to the people I admitted to the hospital. And so I like being with people from the beginning to the end. And, when things outside of our scope of practice happen or patients unfortunately pass away, I appreciate when family members call me and tell me, because I want to be able to go and pay my respects too. And so I think in a lot of ways, this community has really allowed me to practice the kind of medicine I'd like to practice. And so I've gotten to know people like Karen and now Mr. Wilshire and others. And it's just been really, really wonderful. So I want to thank everybody for letting me come. So when Karen said, did you want to add anything else? I added a lot. but just in general, I wanted to be sort of relaxed during this talk and just in discussing everything with people. I know that you all either suffer from neuropathy or care about someone that suffers from neuropathy. And I really think the more we know about it and the more we tell patients about it, the more empowered patients can be. And so when I think about my patients, I really like to think about them as people and individuals. So everybody will experience neuropathy in a different way. When you hear about neuropathy, people will go online and say, what is neuropathy? Well, it's not just one thing, it's many things. The person to the right of me may say that in their neuropathy, they have numbness and tingling, but someone else might have severe, terrible pain. Someone else might have burning pain. Someone else might have stabbing pain. Someone else might get cramps and spasms. Someone else might just fall because they can't feel their feet, but they don't know they can't feel their feet. And so it manifests in very different ways in different people. And so every single person is going to experience their own version of neuropathy. And I think that's something I try to tell my patients right away, that there's not any one way to treat someone that's going to work for everyone. And I think that often is an approach we don't want to have. We don't want to say to somebody, okay, you have neuropathy. Here are the 5 things I can do for you. Have a good day, right? You want to know that there's always going to be hope, that there's always going to be an option, and that I'm not telling you, yes, okay, 1, this is going to change your life. Yes. But how can I help you live the life you want to live despite it? So you don't want to become, yes, it will be part of who you are, but you don't want it to be the only thing that you are. And it can be so cumbersome for some people, and it can be so devastating for others. It just depends on the type, and again, how it manifests in that particular person. So it's so important that we all know, and those who suffer from it understand that it will change over time. There will be ups, there will be downs, there will be plateaus. There may be severe declines. There may be times when you feel a little bit better. The point is, sorry, is someone asking a question? No, okay. I think the point is that no matter what, you're going to have somebody there with you to ask along the way. You need to know, and you need to have relationships with your providers, whether it's me or someone else, where you feel comfortable going to them with questions, where you feel comfortable saying to them, well, what you did last time was not so good. It didn't work. And that's okay. We're not offended. We need to know, or we can't help you feel better. Because again, not every one thing is going to work for every single person. So I know all of you have probably heard of gabapentin, and every doctor will say, okay, we're going to give you some Neurontin or gabapentin, and it's going to work. Well, not for everybody. And some people can't tolerate certain medications, and there'll be side effects. And our job is to let you know what to watch for, what to know. Okay, it might be working, but your feet are now 5 times bigger and you've gained 10 pounds. Well, that's not helping you walk better, right? Or, okay, yeah, my numbness and tingling or my burning pain is much better. I sleep better at night. Thank you. But I can't think of words during the day because my mind is so clouded. I just want to go to sleep. Well, then that's not a good medicine for you. And I'm not saying gabapentin doesn't work. It does in the right person. And so that's why I wanted to share this list with you. This was shared with me when I was in my training, and it's something I carry in my pocket. So that's actually a little size pocket card that I have in my top drawer, and everybody in my office knows where to find it. And though I've copied it for them, they still come for mine. And I love this because on one side, it gives you some options for topical treatments of neuropathy. And then on the other side, it gives you many, many options for oral or medications that you can take for neuropathy or neuropathic symptoms. And it's incredible because some of these medications you would never think, and some of them, like one of them listed on there is topiramate or Topamax. One of the side effects of Topamax is numbness and tingling. Yet, right, here you go. Yeah, but in some people, it actually helps their neuropathic pain. And the numbness and tingling isn't the problem. The problem is the discomfort or the pain. So every single medicine works in a different way, attacks a different pathway, deals with neuropathic pain in a very different way. Neuropathic pain is not the same as when right before I got here, part of the reason why I got here just in time was my son, who's 3, one of my sons is 3, stubbed his toe on the way, and he actually cut it. That kind of pain is very different than neuropathic pain. That pain happens, is terrible, but it's over very quickly. The kind of pain that we have in neuropathy doesn't like to go away, right? It's sort of, and it can be nagging. I feel like that's a really good word sometimes for what some patients experience because it gets so old to have to deal with that same pain all the time. And it certainly is hard and not fair for me to speak like I know what it is because I don't. And so for one of the things I learned in training, and one of the things I really try to say to people is I try not to say, I know, because I don't. I don't know what it's like to be in your shoes, and I don't know what it's like to experience that pain. Now, someday I might, but right now I don't. So I can tell you what I read in the books, but you have to tell me as best you can what you feel and what you experience. So I can try to figure out what I know, what I've been given to try to help. So a big part of what we say, or what I like to say is, no matter what the problem, there's hope that we can help you. There's hope that we can help you live the life you want to live. But sometimes it takes time to get there. And that can be certainly frustrating. And I think it's important that as providers and the doctors that you see, that they let you know that they say, this is something that'll be lifelong and we're going to deal with it together. And it's not that they'll make mistakes, but we may choose the wrong path sometimes, and we may have to go back a few steps to get you back where you were, and then try again with something else, because there is no clear-cut fix-all. In some neuropathies, in very few, unfortunately, there may be. So we say, when we talk about neuropathy in general, there are many types of neuropathy. But when we think about neuropathy, it can affect 2 different parts of the nerve. So the nerve is made of the main part of the nerve, and I'll use my arm. You've probably seen me do this before. But the arm is the axon, or the nerve itself. The myelin is the sheath around it that protects the nerve, and it actually doesn't really look like a sleeve. It looks like bands around the nerve. There's little spaces between them, but it's an easy concept to think of myelin, or that protective sheath, as a sleeve. You can get damage to the myelin, or you can get damage to the axon or nerve itself. The most common type of neuropathy that most people experience is the kind that affects the nerve, this kind. And that's treated in all those different ways I gave you there. The reasons for it are countless. And so that can be one of the most difficult and most challenging things, not just for us as providers, but for you as patients. Well, why did this happen to me, doc? I don't know. And in so many cases, it's because somewhere in our DNA, it's written that someday we're going to have neuropathy. It runs in our family, or we're prone to it because of a certain history in our family. We don't know. And in some of you have probably heard your providers say, okay, in 66% or in 2/3 of you, I'll figure out what might have led to this or what might be causing it, like diabetes is a simple answer sometimes for people. But in 33%, we don't know. And it's called idiopathic neuropathy. I don't like that term because of where it comes from. It means we don't know. But there are certainly still things we can do for it. And so one of the first things we have to figure out is which part is it attacking, because the treatments are different. If you have something that attacks the myelin, usually those types of neuropathies tend to be much more aggressive, rapidly progressive. And so aggressive, rapidly progressive, and sometimes most often require an IV treatment or a pill that actually immunosuppresses you. So it can be almost like an autoimmune disease. So if you've heard of things like Guillain-Barré, it's like a long-term or chronic Guillain-Barré syndrome. Now, Guillain-Barré also can attack either this part or this part. So when we treat that in the hospital, that becomes more complicated because we have to figure out which part of the nerve is being attacked. But when we think about chronic Guillain-Barré, we're often thinking about what attacks the myelin. That's called CIDP. If any of you have heard of that or been diagnosed with that, that can be a much more aggressive, much more progressive, and much more difficult thing to treat. Though both are very difficult to treat symptom-wise, it can be hard to slow that down. And that can very quickly put someone into a wheelchair. So that's different. And it's important that we say that to patients. Say, you don't have that kind. So if you look it up and you see that, that's not you. And that's important to know too. In other cases, I think knowing, so the most common type is going to be that one that attacks the nerve. And that's the kind that we think about. So diabetes is a difficult one because it can actually attack this part, and these are both types. They're called large fiber neuropathies. Then there's this whole other part of neuropathy called small fiber neuropathy. And so if your large fibers are okay, sometimes it's the little tiny fibers. And you're not diagnosed until someone takes a sample of your skin and looks at the number of nerve fibers in it. So I don't know if any of you, I'm sure many of you have experienced an EMG or a nerve conduction study, that thing where the doctor zaps you and pokes you with a needle. Yeah. Okay, I do those. They're very helpful, but they only look at the large fibers. So if I see a patient and I say, well, it's normal. And they say, well, I have numbness. That means I don't have neuropathy? No, that's not what that means. That means I can't see it yet because the first nerve we test is about halfway up the leg. And if somebody has numb feet, we're not going to see it yet. But sometimes it's because you don't have a classic neuropathy where we attack this, or this. In the large fibers, it's actually attacking the very smallest nerve fibers in your skin. And that can happen in diabetes also. It can also happen classically in a lot of autoimmune conditions. If you've heard of things like lupus or Sjogren's disease, you can see it there. You can see it in tons of different conditions, hundreds probably, but many that we think of that are autoimmune. So when we think about neuropathies, one of the first things to think about is it a large fiber or is it those smallest fibers that are being affected? That's often when someone says their neuropathy, if any of this affects any of you, it's patchy. It'll come and go. It'll be like electrical zapping. And people will say that and think, this person doesn't have anything. Oh no, they do. And you can prove it with a sample of the skin. So it's a skin biopsy to look at the small nerves. You look at actually the density. Someone sits and counts under a microscope to look at how dense the fibers are. And that can be attacked also for a number of different reasons. So you're trying to figure out, okay, is it small fiber? Is it large fiber? If it's large fiber, is it the axon or is it the myelin? Then once you've figured all that out, what's doing it? Do I know or do I not know? So initially there's a whole slew of lab testing that we suggest. We look for things like diabetes. We look for glucose intolerance. So people who have not yet developed or had a diagnosis of diabetes, but years before, can have glucose intolerance and be close to diabetic, can start to get neuropathic symptoms. One of the most common, and this may have affected many of you, is B12 deficiency. So we look at B12 level. On the other hand, B6 toxicity. So too high a B6 level can do it. Too low a B12 level. There are things, like I said before, autoimmune conditions, things like Sjogren's or lupus. So sometimes we screen people for that. We screen people for blood disorders where you have a certain amount of protein in your blood. If you have too much of a certain kind, that can lead to neuropathy. There can be exposures. Someone has chemotherapy. Chemo can cause, certain types of chemotherapy can cause damage to the nerves. Exposures to heavy metals. Exposures where we have to think about people who have served during wars. We have to think about exposures they may have had there. We have to think about exposures with insecticides. We have pesticides, things like that. So we go back into what people, one of the questions we always ask is, what do you do for a living? Or what do you do for a living? And that's really important to understand. So you really need to get to know the person as a person, the patient as a person. And then we keep looking. And, so there's those initial tests that we do, and then we keep going. We do more testing, vitamin E levels, vitamin B1 levels. It can get pretty fancy. We look for infections, hepatitis B, hepatitis C, HIV, the syphilis, the list goes on and on. And so when you're getting a very specific workup for neuropathy, the workup can change depending on, is it the small fibers? Is it the large fibers? Is it the nerve? Is it the covering of the nerve? And so neuropathy, I think it's really important for everyone to understand how very complex it is. It is not something that is easy to understand. It doesn't always present in the same way. When you learn about it and when people think about it, it's easy to say, oh yeah, it affects the feet first and the hands first, and then it'll slowly climb up your hands and it'll slowly climb up your legs, and that's what happens. But that's not always true, because small fiber neuropathies can be patchy. They can be normal you can take samples and they'll be normal at the ankle, normal at the hip, and abnormal in the middle. Well, goodness, what do you do with that, right? Or it can be abnormal down at the ankle, normal up here, and it's actually the small fibers, not the large fibers. So it can be very, very complicated. And again, that's why I'm not sure I understand. Okay, my watch doesn't understand, but I was right on cue, watch. I'm really bad at technology too. My patients know that I'm terrible with technology also. So, oh goodness. So at any rate, I think what I wanted to convey tonight was, not only is neuropathy is certainly not straightforward, it's complex. It is very individualized based on the patient. And when you find a provider and when you're working with someone to help you, you want to have someone that understands that you are a person, that there are certain things and certain ways you want to live your life. And it's our job to help you do that, not tell you can't because you have neuropathy. So when patients' neuropathies get really bad, driving doesn't go so well because they can't feel their pedals. So we give them hand controls, because if I take away someone's license, I take away their independence in a lot of ways. And that's not very kind. So I bring it up early on to say, hey, this may come up someday. Maybe it'll be decades from now. Maybe it'll be in 5 years. Maybe it'll be in a year. I don't know, because everyone, again, progresses differently. But if you bring it up early and you're talking about it, people understand. One of the most common questions I get is this going to put me in a wheelchair? And most often, I like to say no. But I can never predict what's going to happen or how quickly something will get worse. But certain types of neuropathy, I can be more confident in saying no. In other types, I have to say, I don't know. But that's why we're going to work together. I'm going to see you every so often throughout the year. And I'm going to be able to tell by what you're telling me and by how you progress over time. We sort of, in our minds, plot, because I have exams from across a year. That's going to tell me how quickly is this progressing. You know, we do things, and I'm going to bring this out. I knew I brought this stuff for a reason. So you all, I know, have seen these kinds of things when you're at the doctor. So good neurologist is always going to check your reflexes. They're always going to check vibration sensation. But again, this is for the large fibers, not the small ones. And then they're going to use one of these things. In your PCP's office, it'll look almost like a little brush, but the neurologists tend to use these little pins. And it's really important that when we examine people, each time you come in, we don't ignore it. We say, okay, we're here for a neuropathy checkup. I'm going to check and see where you can feel me at. I'm going to check and see how your reflexes look. Because as typical neuropathies, those large fiber ones, these axonal ones, as they progress up the leg, I want to know how quickly that's progressing. So I can judge that based on taking this and saying, tell me when you feel that it's sharp. And so if I've seen Karen a year ago and I'm comparing the exam to a year later, I'm going to know if it's worse or not. And I'm going to know how quickly it got there. Reflexes in large fiber neuropathies, as they progress, reflexes will go away. So if you have a neuropathy that affects your feet, you'll lose your reflexes at the ankles. And that tells me, okay, it's progressing. Then if you lose your reflexes at the knees, that's a bigger problem. Because again, as we become numb, we become tingly, as we can't feel things, as we experience that pain, we all do it at different rates and at different times throughout the course of the disease that you have. One of the other things I'll share briefly, and then I can open it up just to sort of open questions and talking. One of the other sort of concepts I like to share with all my neuropathy patients that I think is really important is the idea of how neuropathy can affect gait or walking. So as neuropathy becomes more severe, it causes, you're unable to tell where your feet are. So patients fall. Patients will come in and say, I'm having more falls, I'm unstable, and losing that stability, that equilibrium, we lose that as we age a little bit, so that plays into it. But it also, our nerves age, so that plays into it. But as we lose our nerves in our feet and up into our legs, it's much harder to tell where we are. So that's why I check vibration in people. That's why I'll say, close your eyes. I'm going to move your toe up or down. Tell me which way it's going. And if someone says to me, I have no idea, then we have a problem. And you have to make them close their eyes, or sometimes we cheat. So, and I do it too. So one of the things we have to realize is there will be a time when it can take that ability away. We won't know which way our toe is going. That's why doctors so often will say, check your feet, make sure they haven't been hurt. Because if you have a wound, you might not realize it. And that's just not in diabetics. That's in anybody with neuropathy. So I like to tell people, we stay, and this isn't written in a book anywhere or anything, but I like to think about it this way, and I think it's helpful, and you all can tell me, can give me feedback at the end if it's not. But what I like to say is we depend on different senses to keep ourselves upright and standing and walking straight and not falling down. We depend on our eyes. So our eyes, if we can see the horizon and we can see where we're going, we can walk straight and we don't fall down. How many of you have been on a boat, all of a sudden the horizon's going like this and people are falling all around on the boat, and some people are throwing up over the side of the boat, right? Because they're getting sick. So sight plays a role in our ability to stay stable and upright, to keep our equilibrium. The second area that is really involved is hearing, is our ears. If any of you recall ever getting an ear infection where your ears get really stuffed up, suddenly you're dizzy all the time, right? The room sort of feels like it's spinning. So the ears play a role. We don't realize how much hearing is involved, but it helps a lot with our equilibrium, our ability to stay upright and not fall down. That whole vestibular system, the system that keeps us upright, our equilibrium, a fancy word to say equilibrium, our vestibular system, connects into our brainstem, so part of our brain. If you get a stroke in that part of your brain, it can affect your equilibrium. So that's all connected, ears to brain. Then I tell people, you also depend on your feet. So if I stand up, and I know you're not going to be able to see this perfect, but I'm going to stand up anyway. If you stand up, I'll like bend down a little bit. So if you stand up and I have my feet shoulder width apart, and I close my eyes, I'm good. I'm not falling. And I know if I take a step forward, I'm going to hit the table. My eyes are closed though. See? And then I know if I go this way a little bit, because I can feel where my feet are, I'm going to touch the chair. And if I step this way, I'm going to touch this patient somewhere. There she is. But I do that all with my eyes closed because my hearing works and my feet work. My feet are able to tell my brain where I am in time and space. And so I can figure out where I need to go when. If all of a sudden my feet can't get that message to my brain appropriately, when I stand up, my feet aren't working, but my eyes and ears are. Suddenly I close my eyes and I'm like this, right? And people fall. So if you think about the most common place for people to fall is the shower. Why? Because, one, they have neuropathy. They can't feel their feet. The signal is not getting from their feet to their brain to tell them where they are in time and space. I'm in the shower. I'm at this spot in the shower. I'm safe. I know the wall is here and the other wall is here. I'm good. But that's not working. Suddenly, there's water in your ears. So now your vestibular system is impaired and you're going to get dizzy. And then you close your eyes and tip your head back to wash your hair. What's going to happen? All three systems are out and people fall down and end up in the emergency room. So one of the biggest tips I give to people is when your feet aren't working and that signal is not getting to your brain, you need to start depending on everything else. You need to depend on your eyes. You need to look down and see where your feet are. And that's the only way you can prevent yourself from falling. So people often say, I can walk up steps fine, but I can't walk down them because you're not looking down to see where you're going. But when you're looking up, you are. Yeah. And so that's why it's harder in patients with neuropathy to go down steps than it is to go up steps. Strength aside. But when you're feeling, because you're not looking. So you have to look down. Well, then that brings up a whole nother thing where you have to keep looking up too, because you have to make sure you're not running into a wall. So there's a lot that goes into that, but that's one of the biggest tips I pass on to people, because understanding how those different senses work together and how important it is, not just feeling in general, but that idea of what is called proprioception, the ability to tell where you are in time and space. That test your doctor does when they say, close your eyes. Am I moving your toe up or down? If you don't know, you could fall. And so we have to depend on some of those other systems. But that's just one of my tales, one of my helpful things that I like to share with people that I think is helpful. So again, you can all tell me if it ends up being helpful or not. Overall, that's sort of the key things I wanted to pass on to all of you was, one, I really, am passionate about this, and I want you each to find a provider that you can work with that gives you hope, because neuropathy can be scary sometimes. It is often misunderstood. And we have to recognize that it's a big deal, that it changes lives, and that we can do things for it. We can help. We need the opportunity to do that, but we want to. And sometimes it will take a few steps. Sometimes you will feel like you're taking a few steps backward before we find the right thing that will work for you. But remember, there's not any one thing that's going to work for everybody. So it's not that your doctor isn't thinking about you or isn't good at their job. It's that every single person experiences medications differently, experiences neuropathy differently. And understanding that is key to treating it, because you have to figure out so many different things about it. Is it the small fibers? Is it the large fibers? Is it the nerve, or is it the covering of the nerve? And what kinds of things are contributing? And I think one of the most important questions to ask, if any of you are diabetic, to ask your provider is, okay, I'm diabetic. That doesn't mean my neuropathy is all because I have diabetes. Have you checked my B12 lately? Because I like to look at it as multifactorial. Just because it's one thing doesn't mean something else isn't playing a role. So it's much more complex than just you have neuropathy. 8% of the population over the age of 55 has neuropathy. See you in 6 months. It's much more complicated than that. And there's a lot of things we can do for it. Can we cure it? No. In neurology, there is, people often say to me, why'd you go into neurology? You can't cure anything. There's neuropathy, there's Parkinson's, there's MS, there's ALS, and no, we can't cure it. But we don't have a cure for diabetes or high blood pressure either. And so you find what you're passionate about in medicine, and you do it. And I think I've been so lucky and really enjoyed my time so far practicing here in this area, because I feel like my patients have wonderfully been very receptive to talking to me. And that's so important. And it's so important to take the time to get to know each other. I like when my patients know something about me and something about my family. And I like to know something about my patients, because it keeps us invested in each other. And that's really important to have in your relationship with your provider, whether it's your general provider, your neurologist, your cardiologist, whoever it may be. I think I'm good. Now, I just want to open it up to just general questions about neuropathy, about treatment, about anything.
Do you give all your patients that you just see, do you give them a test for the B vitamins?
I do.
Right off the bat?
Mm-hmm.
Do you?
I do. So that's in my initial sort of, and that was Bill talking. He asked that question on if I check B vitamins in everyone, and I do. Again, that's the idea that, okay, if someone's sent with me with severe diabetes, okay, but they could also be B12 deficient. And if I supplement that, it might help their symptoms a little bit. Or someone might also have too much B6 in their diet, and that might be making things worse. So I do. I always check B12 and I always check B6. And then if it's been a number of years, like sometimes a patient will come to me, they've been seeing another doctor for 10 years, they've had neuropathy for 10 years, B6 and B12 were checked 7 or 10 years ago. But that doesn't mean they're not contributing now, that isn't something that has developed. So I often then recheck it.
Okay. Would you say a high percentage of your patients have a deficiency in Bs or too much?
Right. I would say a high percentage have very low B12. B12, so in every single lab system, there's certain things that are considered normal, certain ranges. So in general, the number we use is people will say, okay, if it's less than 190, you're deficient in B12. In the neurology world, we say if it's less than 400. So it's going to come up as normal, but in actuality, we see that people can have pretty significant symptoms under 400. So we supplement if a number is under 400. And so it's very dependent again on the provider and how they were trained, because everybody gets trained a little bit differently. But I certainly supplement if years ago, it used to be less than 300. Now we say less than 400. So now I'll find some people that I used to do 300 for that I now have to supplement that I wasn't supplementing before. So it's important that we stay up on the recommendations, because that does change over time. Since moving to Back in Hershey, I found maybe 1 or 2 B6 toxicities where they were high levels. And why was that? Well, it could be something in the diet, or it could be that one of the multivitamins they were taking had extra B6 in it. So use a different vitamin.
Yes, yeah.
Well, now that I'm in Southwest PA, since I've been practicing here, I feel like maybe 1 in 15 has extra B6, which is a lot.
Yeah.
And so I find a few a month. And I have to say, okay, so I've really learned what foods are high in B6 because I've had to look it up multiple times. But we don't know the reason. There's hypotheses out there about what can lead to high B6, certain vitamins or supplements that people take is that causing that number to go up and then contribute to their neuropathy, but we're not sure.
Okay.
I have a couple questions. First question, outstanding presentation.
Oh, thank you.
Yes.
Bedside manners, incredible. Really good. Not too many doctors come across as well as you've come
Thank you.
across here. And you do see patients, so if I take the card and call, okay. All right, and then just curious about any recommendations for supplements. I hear a lot about alpha-lipoic acid. We had a fellow come here, he went and he talked about how alpha-lipoic acid, and I've taken it and I've had like virtually no success.
Improvement,
myself.
okay.
And then diet. Is there anything that
Sure.
you suggest, recommend, stay away from? Anything you suggest go towards?
Okay, great questions. So first, I would say in the realm of supplements, I'm all for it, but I ask that people tell me what they're taking, because sometimes in those supplements are added additional things, additives that can be dangerous for the nerves. And so I always want people to bring in their bottles for me so I can look at it with them to say what's good, what's not so good. No, I want to say, and I'm going to hedge here a little bit, there's nothing specific that I recommend to my patients. I use sort of an overarching concept, which is anything that's an antioxidant. So fish oil, vitamin E, vitamin C, anything that's an antioxidant is helpful to the nerves and to the nervous system. So I look at it as a whole because I want to treat the whole nervous system. So I say supplement wise, anything like that is going to be a plus. Okay. People will often bring into me some of these newer things that combine a whole bunch of stuff together. And they'll say, I got this. And I'm like, that is great, but don't waste your money because you can buy all that stuff over the counter separately. Because they'll just take a bunch of antioxidants, mix them together and call it a special, whatever that is. And so I say just in general, antioxidants are really good. From the standpoint, what was your other question?
Diet, anything.
Oh, that's right. Diet, not specifically, stay away from or avoid. I recommend a Mediterranean diet to most of my neurology patients. It keeps the brain healthy. It keeps the nerves healthy. So a big thing is to eat a little more fish than you're going to eat red meat. Having red meat in your diet is important because we don't want to get anemic. So I never say don't eat red meat at all. You know, you want to have it in your diet, but you want to have it minimized. Chicken is the same way. Chicken's actually really high in B6, which we don't want too much of, but chicken is extremely healthy. So you have to be careful about that and how much you're doing it. So you don't want to eat chicken 5 days a week.
And we do.
So
Try to stay away from
we need to check your B6.
Try and stay away from red meat, eating a lot.
And that's what happens,
Yeah.
right? And we all try to do what we think might be best, but every single provider is going to tell you something different. And so if I can generalize it and say, lean toward a Mediterranean diet most of the time, but it's okay to do some red meat. It's okay to do nuts and things like that, that you still need those types of vitamins and those fats, that and carbohydrates. It's okay. And my recommendations are obviously different when you have a diabetic patient, because then that has to change and the number of carbohydrates has to, all those things. So, but in general, we stick with that. I also think one of the biggest things you can do more naturally is exercise. And so many of my neuropathy and myopathy muscle patients will say to me, what? I'm too sore. I can't. I spasm all the time. I'm numb. I said, that's my job. I have to fix your symptoms so that you can live your life. But the very best thing for the nerves is to remind them what they're supposed to be doing. So if I like this analogy too. If you take a brain and you put it in a dark room and you close the door, it's not getting any stimulation. It's not hearing any voices. It's not watching TV. It's not interacting or socializing with people. What's going to happen to that brain? It's going to shrivel up. Parts of that brain are not going to work anymore. You're going to go back in and it's going to look terrible. Same thing with the nerves. If suddenly we're not stimulating those nerves because it's too hard for us to walk or exercise, then suddenly those nerves are going to say, I'm not needed anymore. What have I been doing all this work for? And they shrivel up more. And so that idea or that concept, I think, is very helpful. We want to consistently and persistently stimulate those nerves to do the job they were made to do.
One more quick
Yeah.
question. I just read this morning, because I ride a recumbent bike.
Oh, good.
30, 40 minutes.
That's great.
But I just read this morning, peripheral neuropathy, blah, blah, blah. Walking is like the most superior thing. The bike riding's nice, you're doing great for your heart, but walking is what will absolutely be the best exercise for the. So you're on board with that also?
Absolutely. It just is the way you're stimulating the nerves to move.
Okay.
But the fact that you're doing any level of exercise is going to be helpful to those nerves.
Okay.
So if you're enjoying the bike, it doesn't mean give the bike up.
Okay.
Add a little bit of walking. I think that's great,
Okay.
but it doesn't have to just be walking.
Okay.
You know, there's a lot of theories out there, and next year it may be, oh, we've discovered that if you jog, well, I'm going to tell you right now, I'm not jogging anyway. So I don't care how much somebody tells me to do that. I've never done it. So I jog when I have to run after my children when they're doing something they shouldn't, but otherwise that's not me. And so you have to, again, think about the individual. So you enjoy the bike, that's great. Maybe if you could walk once a week. I don't know if you belong together or not. I guess okay. If you, maybe once a week you decide to do that together now that the weather's hopefully changing for the better.
We take our dogs for walks.
That's perfect. That's perfect.
Yeah.
And then doing the recumbent bike in addition to that is great.
Bill, Diane Malwitz has her hand up.
Do you want to know about the B12?
How do I-
think
Is
she's.
she on here?
Yes. Uh-huh.
Yeah.
I have a question. My question is, I have peripheral neuropathy. Well, I also have erythral myalgia too. But
You also have, I'm sorry, say the second part.
I have peripheral neuropathy, but I also have erythral myalgia too.
Okay. Okay.
With my peripheral neuropathy, I've had it probably 4 or 5 years, and fortunately, I do not have any pain, at least not yet. I don't have numbness and I don't have tingling, but I have the most constant, annoying feelings in my feet all the time. I just hate having my foot on the floor, whether it's sitting, whether it's standing, whether it's walking. And I'm looking into considering one of the newer high frequency 10 kilohertz spinal cord stimulators. Is that something that I maybe should look at and consider that might be helpful to all this paresthesias or annoying feelings for my neuropathy? Is that worth looking into, or?
So I don't want to say that it's not helpful, but I have to say that those patients that I've had that have done it have not found it as helpful as they hoped. That
Okay.
doesn't mean there's not a role or a place for it with the right patient, but I have not seen it be as successful as you'd want it to be when you go through such a significant surgery. And so I recommend patients that before they do it, they make sure they've exhausted all other options with various topicals, some of the alternative treatments for medicine, which are certainly an option for some people, as well as some more of the oral medications. Again, both of your conditions make treatment for you much more difficult or more complicated, but there are certainly certain things that we'd want to make sure had been exhausted before you went ahead with a surgery like that. However, I do think it has its role. I just haven't seen it personally be as successful as I know my patients would like or I would like, but that should my experience. Someone else's might be very different.
Are you familiar, are the newer high frequency spinal cord stimulators that have been out the last maybe 4 years or so, is there a chance that they could like damage your nerve to that? I mean, is that a...
So there's always a chance locally where they place the stimulator that there can be damage. I've had some patients have those types of side effects. Not necessarily damage to the nerves that are already damaged from the neuropathy. So not looking at it that way, but looking at it as, oh, it has led to a new problem with pain, but for different reasons. So my experience with it is minimal, but when I've seen it, it hasn't been as successful, like I said, as I would like.
Okay.
Doesn't mean that there aren't neurologists out there that have maybe seen it used more in different ways where it has worked. I just haven't seen it.
Well, thank you. You are just great. I wish we had muscular neurologists like you all over, like right here.
Thank you.
You are just fantastic.
I appreciate that.
Yes, you're great. Bill would like to know, how do we know if he has neuropathy? He was diagnosed by a doctor, and how do you really know?
So there's a number of ways you can know. So some of the symptoms that Bill might share with his doctor would certainly be an indication. So numbness, tingling, burning pain, zapping pain, things like that. If there's no symptoms, but somebody's falling, sometimes we find that people have neuropathy. So sometimes it's due to gait changes, instability with walking. Sometimes people will come in and just say, I am off balance, and nobody can figure out why I'm off balance.
That's what Bill had. His symptom was he couldn't get his balance. He'd stand up and that was his first symptom, wasn't it, Bill? You couldn't get your balance.
Yeah.
And that is when he went to his chiropractor, and the chiropractor checked him and said, well, Bill, you need a neurologist.
Yeah.
And he sent him to a neurologist, and the neurologist tested him.
Yep.
And he did tell Bill he had peripheral neuropathy, but he absolutely did not say there was anything to do for it. And he said Bill was doing, that was like about 4 or 5 years ago.
Okay.
We really, things are a little different. I mean, he is going to a chiropractor now who's putting lights on his legs.
Okay.
And
Are they effective?
Some people some people feel better after getting those treatments. So I tell people it's okay to use. There's no clinical trials that say they work. Does that help? So there's no data that we cling to in our neurology world that says, okay, this is going to be a great option.
oh, what's the treatment for neuropathy? Bill wants to know.
No problem. So I'm gonna go back to his first question, which was, how do we know he has it? So it's not just his symptoms of being off balance, but it would also be all of these things that someone tested to prove it, plus either an EMG nerve conduction study, the zapping and the poking.
Right, that's fine.
And if that's normal, then the skin biopsy. So you need to go in that order. And then there's this whole other realm, which I didn't mention yet, but it's called autonomic neuropathy. And sometimes that goes along with small fiber, but also can just present as what's called dysautonomia. Your heart races, you pass out. There's a whole different, you have urinary trouble. It's a whole different realm of neuropathy.
We had a guy here that had diarrhea constantly.
Correct.
Quit his job because of that.
Yes, and that's a dysautonomia or autonomic symptom. So skin, yeah. You can get a nerve biopsy. That's done when they're trying to figure out, is it the nerve or is it the covering? So they'll do biopsies for that.
Okay.
But a skin biopsy is for small fiber versus large fiber. So they'll do all of that to figure out if someone has neuropathy. And then the treatment for neuropathy are the things I said. So you'll do all that testing to figure out what caused it. If we can find a cause, we treat it. And we try to make it better. We're not going to cure it, but we try to slow it down or help it feel a little bit better. Then we use things like that sheet I gave you of topical ointments and medications that can help with the symptoms.
Okay.
And physical therapy is really important because that's a big part of learning how to walk without being able to tell where you are in time and space, right? That's working on that one element of how you walk more stably.
So Bill he did say, he wanted me to ask you, what exercise is good for Bill's peripheral neuropathy? Would it be daily walking or gym?
Daily walking.
Okay, you can walk daily, Bill.
Well, I had that light therapy and it helped me.
Yeah.
Okay,
So
that's very good then.
different
I mean,
people, different results, and that's great.
But we don't really know what happened when he first had his first things done. You know, like you were talking about.
Mm-hmm.
Because the doctor never really checked him. He didn't want to check him again. He said everything is, there's nothing to do for it, you know.
Right. So I think that's where one of the misconceptions is. And that's what I wanted to talk about, that there is really a lot we can do and a lot of different things we can understand and a lot of ways we can try to help. And it's important to know if he's had it this long, how much has it progressed? What does it look like now? How can it affect his
That would
life?
be very interesting to
Right.
know, but I guess we could get an old record from a doctor.
Yep. And then we work together in that.
Because he, I'm sure, has everything. Yeah.
Did you have a question?
Yes, I have a question. It's actually a follow-up.
No, she's not.
Two people are talking, sorry.
No, you're okay.
Couple more questions.
Go ahead, Pat.
Yeah, when it's
Go ahead.
done.
It's sort of a follow-up to your autonomic neuropathy comment. My sister has been diagnosed with peripheral neuropathy, diabetic peripheral neuropathy for several years. Recently, for the last 6 months, she has struggled with gastric issues, serious pain and constipation. They've done the colonoscopy and even looked at an MRI of her large bowel. They've looked at everything and said everything is fine. All the organs are normal, but she has constant pain. And they've decided that it's autonomic neuropathy as opposed to peripheral. Is there anything that one can do? I mean, is she destined to just use Miralax for the rest of her life?
So sometimes that does become part of daily life for people. There's more and more research being done in this area. So autonomic neuropathy is a fairly new thing, a fairly new concept, and we learn more and more about it all the time. And so over the last 5 years, there have been various dysautonomia or autonomic centers that have popped up. And so reaching out to a specialist there would be helpful to her. It sounds like maybe she's close to one already. I don't know. But that can be a very big source of information because they have a lot of trials going on right now for different opportunities for treatments.
How do you find someone? I mean, it's hard enough to find a neurologist who knows what you have so beautifully presented tonight. I wish you would move to Washington, D.C.
But, well, what I can do is I have a list of them. I can certainly send them to Mr. Wilshire and he can share them with you.
Excellent.
And that would get your, absolutely. That would get your sister started. Did you mention that she also has diabetes too?
Yes.
And dysautonomia, that autonomic dysfunction, is a very large part of diabetes. Because when we think about diabetes, it's an autoimmune disorder. So she has a lot of dysfunction in her own body. And so fighting that and treating that can be so much more complicated. And again, very individualized. So I'm sure there's certain things they've tried, but there are other medicines that have both GI, that can give us good GI results, but also treat neuropathy. And those would be something to discuss with her doctor. But I can certainly recommend some names. Is she in the DC area?
Yes.
Okay, perfect. I'll get names to Mr. Wilshire of where the autonomic centers are, but I'll also focus on that area and give you a couple names.
Excellent. Thank you so much.
Okay, thanks. Yes.
Does hip knee replacements have anything to do with neuropathy or?
So I don't want to say they don't have anything to do with it. I think you have to consider if someone has significant neuropathy before they undergo a knee surgery or a hip surgery, because you have to prepare them for how it's going to change things or how it might affect recovery. Certainly doesn't mean you shouldn't have them replaced. It just means it can play a role. We often also will get people that sent to us that will say, and this happened a lot more when I was at Hershey, which was an academic center, so we got a lot more of the more difficult questions where we couldn't get answers for patients, much like your sister went through. So what will happen is, and I just totally lost my train of thought. It just went right out of my head. Yeah, thank you. Okay, so when patients get referred to us, they'll say, suddenly, I know, it's been a long day.
Yes.
Suddenly, I worked all day, then I went home and cooked dinner for the 3-year-old and 5-year-old husband. So like you get, so hip and knee, got it. So people will come and say, you know, I've had neuropathy for 5 years. Suddenly my hips are really weak. It must be my neuropathy. Well, what happens a lot of times with hip and knee weakness, hip and knee problems, is you'll get weakness in your leg. And it's not progression of neuropathy at all. It's that your hip flexors, your quads, can actually get weak because of difficulty with a hip or a knee. So the arthritis plays a large role in that. So the neuropathy can actually feel significantly better once someone has dealt with the arthritic discomfort in the knee or the hip, because suddenly the top of the leg is working much better. It's a great question.
Well, I just had hip replacement, and I think my neuropathy is a little worse than it was before that.
And that can happen too, because what happens with anesthesia is we tell people any neurologic conditions, anesthesia can make it worse. So surgeries can make it worse. When we have Parkinson's patients or dementia patients, ALS patients, we'll say, yes, you need the hip replacement, but I don't know how it's going to affect your disease overall. Just like sometimes we don't know what sets off neuropathy or what sets off ALS or what sets off, like, why did I get Parkinson's now? It happened right after I went swimming in that Florida beach, or whatever they're relating it to, or right after I had neck surgery, I got Parkinson's. So we often think about neurologic diseases and think to ourselves, among us as neurologists, is there something in our DNA, our genetics, that make us prone to these diseases, and then something in the environment we encounter that sort of sets it off or makes it more prevalent? Yeah. So I think in a lot of ways it's similar to that. So I'm not surprised that you say that. I've heard that many times before. Yeah. And it's not directly the medicine that does it. It's really the trauma to the whole body when you go through a surgery.
Right. Yes.
Go ahead.
Yes, doctor. Yeah, I'm Debbie. Debbie.
Hi, Debbie.
Hi. You were so informative. I just want you to know that I've had neuropathy. I was diagnosed just over 20 years ago, and in Jersey. I don't know if you're in Jersey. If you're familiar with Morristown Memorial Hospital.
Okay.
And the group of doctors that I saw there, they had done EMGs. And at that point, this was like early on, I couldn't feel anything from my toes all the way up to my thigh. Yeah. And my arms too, both upper extremities and my 2 lower extremities. And they sent me to New York. I went to Columbia Presbyterian. And I saw a doctor there who was he was actually retired. He was from England. And he was the head of the neuromuscular, diseases. And I had genetic testing done because they wanted to pull out Charcot-Marie Tooth. Okay, so here I am now. 20 years later. Oh, and I also have Ehlers-Danlos syndrome. And I want to know, is there a link between Ehlers-Danlos and neuropathy?
There is. And so a lot of people have the conditions concurrently, and then dysautonomia plays into that world a lot too. So there are certain genetic studies that we do and things that we look for in patients that have both neuropathic symptoms and have Ehlers-Danlos. But when you have that, there is a more, I don't want to say an increased risk, but there's certainly a connection between the two because we often see them together. have you lost the muscles in your hands?
Oh yeah, you could see when you look at, if you look at my arms.
I know, I can see already. That's when you were talking and the certain way that you move your hands when you touched your hair, I can tell that there are certain muscles that would be missing. So I recognize, I mean, it was great that they checked you for CMT because that's often something we see. Charcot-Marie-Tooth is a genetic disorder that people inherit that leads to neuropathy and significant neuropathies. They can be axonal or demyelinating, so the axon or the myelin, most often the myelin, but there are tens and tens of different types of CMT. Also something that can look like what you have or how you manifested your neuropathy. That's one of those severe, significant ones I was talking about where it's the myelin more often affected, those demyelinated diseases.
Not very advanced. Like I know, I've been to many doctors and they—
Did they diagnose you with CIDP?
With what, the Charcot-Marie-Tooth?
No, CMT. Did they find that you were positive for CMT? Or did they diagnose you with CIDP?
What's CIDP?
Chronic inflammatory demyelinating polyradiculoneuropathy. But
I've never heard that before.
That's what your muscles look like. So ask someone if you have that. But did they give you a diagnosis for your neuropathy or say what kind it was?
You know, I've had different things. Sensory motor neuron disease. Does that sound familiar? Or
Sensory motor polyneuropathy is certainly a type of neuropathy, but my guess is you have the kind that attacks this part of your nerve, which, like you said, can be more aggressive and lead to that muscle change.
What is that called again?
CIDP.
CIPP?
D as in dog.
C is in Charlie,
right.
I, D is in dog, P is in Paul.
Paul, okay.
Yeah.
CIDP.
Right. It's on the chat.
Okay, it's neuropathy. Okay. You know, also, can I ask you another question real quick?
Sure.
Your ulnar nerve, does that have anything to do with neuropathy?
Well, it can be affected in any type of neuropathy. So you can get a focal neuropathy where you just have your ulnar nerve affected or the nerve at your wrist, and that's called carpal tunnel. So you can have a focal neuropathy that just affects one nerve. You can have a polyneuropathy that affects many, and that can also include the ulnar. You can have something called mononeuritis multiplex, which affects various nerves in different arms and legs and places. Wow. You can have, so there are many, many different types.
Wow.
Diabetes can just cause ischemia or death of one nerve, one place, and it's from diabetes. So there's lots of different things.
Okay, because I've been to neurologists in the past, but the neurologist that I went to was the head of Lehigh Valley Hospital. It's LVH. I'm out in the Lehigh Valley in Pennsylvania.
Okay, I studied at Hershey, so right there.
Yeah, okay. It was, Dr. Mackin, his name was, Glenn Mackin. He had passed away maybe 4 or 5 years ago. And, I saw another neurologist, but to be honest with you, I don't like follow-up appointments, reminders or anything. And I live like with chronic pain. I live with it. And you were talking before about driving. That's something that has just entered my life now. I'm at the point now where, like, my 2 kids, they don't even want me getting in a car anymore.
Sure.
And it's really scary because what
Absolutely.
happens here is my left foot, I have to constantly be thinking, my brain constantly be thinking, you got to keep that foot all the way to the left because I actually got it stuck under the brake pedal a few times.
How scary is that? Exactly.
It's very scary. And my right foot, I can't feel the gas pedal or the brake pedal.
Can you lift your foot up, like lift your toes up toward your head? No. You have foot drop. She has CID.
I have a bilateral foot drop.
Oh, yeah, there's your AFO. Yeah. Do you have AFO?
I wear MAFOs also.
Yeah.
Crazy.
I love MAFOs.
Well, for me, I don't walk either, so that it's really,
Right.
you know, it's very, very tough for me. What I do is I basically have to, what's the word, transfer.
Yeah.
She has dog foot?
Yeah, she
Someone
said
told
she
her?
has mophos.
Okay.
Yeah. If you were negative for CMT, I'd ask your doctor about CIDP.
Okay.
But I can only see your hands, so that's I'm just throwing it out there. But pleasure talking to you.
If you look at my legs, they're very thin. I mean, I've atrophied.
I'm sure. I'm sure.
You know, I've just lost some muscle. All that
Mophos
muscle.
are a modified AFO. It's just a fancy, so AFO is that.
Okay.
Ankle foot orthotic. And then a mopho is a modified ankle foot orthotic. So it has
Right.
extra parts to it.
Okay.
And then you can get a carbon fiber AFO, which is a lot lighter, but then doesn't do as well of a job as lifting up that toe.
See, his is just like plastic and then it goes, put your foot in. You have a foot.
She's still,
The one that has your AFO.
when she's got, we'll ask her, when she gets
Yeah, it's
10,
just
we'll ask
like
her
it goes
another
down like
question.
this.
Oh, yeah. That's an AFO.
Okay.
Yeah.
Right. It helped him a lot.
Is the leg
Yeah.
swelling and pain, and is leg swelling a symptom of neuropathy and some pain in toes?
Yeah.
Could be that? Okay.
Swelling in the legs, coldness. People often will say, oh, my feet turn purple and they get really cold. Do I have a vascular problem? And they'll end up at the vascular doctor instead of with me. And in reality, it's the neuropathy. So neuropathy, you can see those color changes sometimes. You can see swelling. You can see, you'll feel coldness. You'll feel numbness. You'll feel tingling. You'll feel the pain. You'll feel.
That's what she's saying.
My feet feel cold. Touching them
More, yeah.
That's weird.
It is, absolutely.
Understand.
Goes with
What's the
with
cure?
neuropathy. He wants to know cure.
There is no cure. I wish there was. I wish I could cure you.
Yeah, but
I
they can
can't.
help, but they can't.
Yeah, but we have lots of options, so.
What exercise? Oh, we got that one.
Yeah.
And wonderful. Your number. Here she must be good. It is good. I have a friend up there. She's in nursing.
Okay.
But,
You should
No.
move to this area.
a nitric oxide. Dr. Sean Ritchie's chiropractor for the legs. He gives those lights. He gives them some nitric oxide to take. Is that, he
Supposed to
said it
open your
makes
blood vessels.
oxygen goes in. I don't know if it's good or, Bill's taking it one a day. I don't know, but
No good?
Nah, you don't need it. You don't need to take it. You can, but
it might not.
again, it might not work. Yeah.
My first sign of neuropathy was I felt my socks were stuck on my
A lot of people.
Dentist office.
and put my foot back in, it was still like that.
Yes.
That was my first.
Yeah. I'm not surprised.
I had no idea what
It is very interesting that what different symptoms different people have.
My first symptoms were my feet burned all the time.
Really?
That had to be torture.
If they didn't burn, I noticed it.
Okay.
Yeah.
That doesn't happen now.
That's good.
Dr. Mazzwicki said his nerves are probably dead.
Yeah, that's what happens. They make a lot of noise when they're affected, but then when they go away, you don't feel it so much.
Right.
Doctor, what medicine does really help these legs?
That's what I passed out for you guys.
Oh, all these medicines here. Oh, great.
Okay.
Yeah.
And
Yeah, I
then
see them here.
any kind of antioxidant.
Antioxidant. Okay.
You got it.
Okay.
Like fish oil, CoQ10, vitamin E, vitamin C, all those things.
Okay. Now,
Okay.
Bill takes 500 a day of B12.
Perfect.
Now, he was taking 1,000, and since Dr. Gamalo, I mean.
It would just depend what his number was, so he could.
He went way up, so I told him, doctor wasn't really, well,
It-
we're just doing it. He was on, it was over 1,000, so I went down and told him to take half, 500.
Okay, either way,
Okay.
it's okay if it's high. It
Yeah.
won't hurt him if
Okay,
it's high.
Okay.
So B12, it can be high?
It can be high and not be a problem.
Any
But
other
B6 can't
Any
be
other
high.
questions from the Zoom people?
Pain medicines, if you have pain, you can take it.
It was a pleasure to meet all of you via the computer. And Pat, I will get that information to Mr. Wilshire for your sister.
I just am just really appreciative of your time.
Sure.
tonight.
Absolutely. My pleasure. Thanks for having me. And thanks for helping set this up. This was great.